Hello everyone, my name is Elamin Abdelgadir. I'm an associate professor of endocrinology at Mohammed bin Rashid University and a consultant endocrinologist at Dubai Hospital. And with me today, a world-class leader in field of diabetes, Professor Alice Chang from University of Toronto. Hi, Professor.
Thank you so much for allowing me to have this conversation with you. I look forward to it.
Our pleasure. Thank you very much for coming all the way to Dubai. So how do you see the EDIC going this year?
Great. I'm very impressed with the organization of it, the agenda, the topics, the speakers. I mean, I've had a chance to sit in on a number of sessions and I've learned a lot. So I appreciate the invitation to be part of this.
Brilliant. Thank you very much. And we look forward to see you year by year.
Oh, I hope so. I hope so.
Okay, great. Professor Alice Chang, that over the last couple of years, we have started hearing about the cardio-renal-metabolic syndrome. Can you summarize how does cardio-renal-metabolic syndrome look like?
Sure. So cardio-renal-metabolic, cardio-kidney-metabolic, cardiovascular-renal-metabolic, it goes by many names, but it's essentially a framework to think about entities that coexist commonly in the same individual. Cardiovascular diseases like atherosclerotic cardiovascular disease or heart failure or atrial fibrillation, along with kidney disease, chronic kidney disease, along with metabolic diseases. So metabolic diseases like type 2 diabetes, obesity, I would add to that mast cell D with liver disease. The fact that all three of these entities tend to coexist often in the same individual, that's what we're talking about. Now, some of the people watching this or listening to this is going to think, well, that's not new. Like we've known about that for a long time, and I would agree, it's not new.
Yeah.
It's not new to endocrinologists. It's not new to diabetologists because we've always thought about the whole context. But I think for some of our other colleagues, it's a nice reminder that these things coexist in the same person. So if you see one, then you must go looking for the other one and trying our best to prevent and treat very early.
Excellent. So you mean that the active surveillance for the other partners in the syndrome has to be the practice or the routine practice.
Correct.
For everyone.
Correct. And it should be for everyone because like I said, I think in the diabetes space, we've always done that. We've always looked for the kidneys, always looked for the heart disease. But I don't know that our cardiology colleagues in a patient with heart failure was necessarily screening for diabetes or checking for urine albumin creatinine ratio. They probably were not until recent. So I think it's a very useful reminder that let's find the partners early because we can do something to help those people.
Okay, that's great. So diabetes is no longer how much is their fasting blood sugar or fasting blood glucose or the post-meal blood glucose. It's way beyond that.
Way beyond that. I think recognizing it's the whole person that we're treating, and diabetes is just one part of an important part of what's happening, but they are at risk of so many other things, and we need to be proactive in those individuals.
Yes, indeed, exactly. So, how does the high blood glucose lead to all this?
Okay, that's a fantastic question because I would say that it's not the high blood glucose that leads to all of it. I would say that high blood glucose contributes to many of those components, but I actually think it's the foundation that's common amongst the cardio, the kidney, and the metabolic diseases. And that foundation, multifactorial, right? That foundation is adiposopathy, so abnormal fat producing being a very pro-inflammatory substance. I think it's genetics, it's environmental insults, it's common risk factors like hypertension, dyslipidemia. So I think it's almost, if you think of a tree, it's almost the roots of the tree are the same, and then you have the trunk and then different branches, and those different branches are cardio and kidney and metabolic. And hyperglycemia contributes to the cardiovascular risk and the kidney disease development, but it's by no means the only thing that causes those diseases, right? So I think it's common foundation, common roots with these branches coexisting, and then each branch then impacts the next branch. and then it becomes a vicious cycle.
Excellent. So the common soil hypothesis.
Yes, exactly.
Excellent. Okay, so you've just mentioned that us, the diabetologists and endocrinologists, this is sort of our routine practice for many years. So how easy to implement this active surveillance for our colleagues in primary care, internal medicine, in other disciplines as well?
I think it takes time. And it takes cooperation and collaboration and a lot of education, as always, to put everybody on the same page. Because I truly do believe it is all of our responsibilities to do that screening and to do the interventions that will alter the course. But we need to help each other out, right? Because if one person forgets to do something, the other person can also screen for things. So it's not just on our primary care colleagues. They have a lot more responsibilities than we do, right? So I don't think it's fair to expect them to do everything. However, I think we need to support each other and to remind each other, and that's where systems things are important, right? Whether they're checklists when you see individuals, reminders in the electronic medical record, but things within the system that will remind us, because relying just on the human is hard, because we have so many things to do and remember, that we should take advantage of technologies that will help to remind us. And I think we need to bring in the general public, because the onus is not just on the healthcare professionals to remember to do things. I think if the general public is educated about this, right? If there's television ads that say, if you have this, then do you know about these other things? So then they go to their doctor and say, hey, I heard about this. Should I get checked for these other things? So I think we need to actually involve all the players in the team, especially the people living with them.
Interesting. And you've mentioned yesterday in your talk that now we are increasingly seeing this in non-diabetes professional society guidelines. You've mentioned that in other disciplines have already started concurring on this.
Yes. Yes, and it's a beautiful thing. So the AHA, the American Heart Association, a few years ago in their presidential advisory, this was the topic they chose to focus on. And a beautiful, well-written manuscript and identifying stages of CKM, but with a cardiovascular focus, because their audience is cardiovascular. So the final stage being that of cardiovascular diseases. But very similarly, on an endocrine diabetes side, we could write something similar where the metabolic piece is most important. And it's often we will joke whether it should be cardio-kidney metabolic or metabolic kidney cardio or who goes first.
The egg or the chicken.
Right, exactly. But at the end of the day, the same individual who has one may develop the others. So our job is to catch them when they have one and then prevent them from getting the others.
Fascinating. And I believe it's an exciting time that has brought the cardiologist, nephrologist, internist, and diabetologist to a one round table. Mm-hmm. So we're speaking the same language now.
Yes, absolutely. And I think in the future we would need to add hepatologists to the table, right? Because we are recognizing the importance of MASLD in this syndrome. So we need to add hepatologists. And I'm sure down the road we will probably be adding respirologists and pulmonologists with the obstructive sleep apnea piece. So I think it's a recognition of the underlying soil, the underlying roots, and all the different branches that may come, and we're all there to help that same patient.
Excellent. So we'll be needing larger rooms for ET meetings.
Larger rooms, definitely.
Excellent, brilliant. Okay, so probably you agree with me, Professor Chang, that when we started the diabetes medications, we didn't expect that we will sail so far. So most of the cardio-renal protective medications now, they were in the first place just to minimize the blood glucose.
Yes.
So how do we explain that those were initially were just glucose lowering agents, and now they are cardio-renal protective medications even in absence of hyperglycemia?
Correct. And it's been fun to watch. I'm sure you would agree, right? Over the last number of years, it's been fun to watch. These were therapies, so namely SGLT2 inhibitors and the GLP-1 based medicines. They were born in the diabetes world, right? They were birthed in the diabetes space for the purpose of addressing hyperglycemia. And then it was discovered, actually, they do other things. So starting with SGLT2 inhibitors, the benefits for blood pressure, benefits for weight, and then recognition of kidney benefits in the studies. And so EMPA-REG outcome, I think, was huge. It was a huge study in the diabetes world because for the first time, an anti-hyperglycemic did way more than just impact sugars and indirectly helped outcomes. It directly helped outcomes and then happened to lower blood sugars. So it really was a big change, a big shift from what we had originally expected. But I would argue, though, that we've seen this before in medicine, right? So ACE inhibitors and ARBs were born in the hypertension world. They were designed to treat hypertension. And then initially we were told, do not use them in people with kidney disease because it's bad for the kidneys. And then we were told, no, actually, it's good for the kidneys and it's good for heart failure and it's good for vascular protection. So we've heard this story before. But so then SGLT2 inhibitors followed a similar path, except they started with glycemia and then turned to, actually, there's kidney protection, there's heart failure reduction and cardiovascular benefit. And then the GLP-1 receptor agonists, similar story in that it started in the glucose space, then in the weight management space, and then discovering the cardiovascular benefits of it with diabetes and even outside of diabetes in those with overweight, and then kidney protection in those with diabetes as well, and then a whole slew of other things that we're learning about the GLP-1 class. So it's been amazing to watch. And then in terms of the underlying why, I mean, that's always a fascinating question. I mean, the mechanism of action of the SGLT2s and the GLP-1s are very different, but impacting inflammation seems to be an important core piece to both. And then on the GLP-1 space, the reduction in adiposity seems to be an important part, visceral adiposity specifically.
Yeah. So the inner fat is a bad one, right?
It's the bad fat. Agreed.
Yeah. And the subcutaneous fat is reasonably healthier than the visceral fat.
Correct.
Okay, I know you are a big advocate for the muscle D, or the NAFLD in the earlier nomenclature. In your understanding, why the pace of acknowledging muscle D took much longer than acknowledging other cardio-renal metabolic?
It's a great point. I think for the longest time, we all knew about fatty liver, but it was like, you have some fat on the liver. Like, it was not a big deal. And then it became, actually, it could lead to cirrhosis. It can lead to fibrosis and cirrhosis. And then it's only in the last maybe 5-6 years that we're starting to see guidelines, documents from ACE, from ADA, from sort of the endocrine diabetes world actually coming out and saying, no, we need to actively do something about it. And I think it, again, have to do with time and recognition and collection of the data to demonstrate from an epidemiologic perspective the strong relationship. Admittedly, I don't think it helped that the name kept changing, so that did not help. But now I think this name makes a lot of sense, and I think this name brings everybody in because it's metabolic dysfunction associated steatotic liver disease, right? So if it's metabolic dysfunction associated, okay, so this is not about alcohol, this is about metabolic dysfunction. It's about insulin resistance and obesity and perhaps hyperglycemia. And then I think now we also have therapies that, again, born in the diabetes space, like GLP-1 based medicines, which actually have biopsy-proven data to show changes in steatohepatitis or changes in fibrosis. So actually changing outcomes, not just making AST, ALT numbers change, but actually proven. So I think from a therapy perspective, there's now something that we use already in the diabetes world that can expand and also help. So that's probably why the conversation has really increased now.
Okay. So now we can hit several birds with one stone.
Yes,
Great,
multiple.
Great. Since the time of Empiric, we've started sharing the statement that this is an exciting time to treat diabetes.
Yes.
And every year we renew this statement with the new discoveries.
Yes.
So now we have the single agonist, dual agonist, triple agonist is around the corner.
Yes.
Quadruple agonist probably also on the way. So how do you see the future of this cardio-renal metabolic?
We're getting more and more toys to play with, I guess is one way to describe it, right? It's exciting, and it's that whole field of, the current term is NUSH, right? So the nutrient-stimulated hormones, and better understanding of all the different ones, and it almost becomes a mix and match situation where we're going to need to figure out, for this person sitting in front of me, what are their biomarkers, their phenotype, their features, and how will that help me then help them decide which one to use? Because you're right, there's going to be many. Now, the reality of the world is that a lot of those decisions will be based on systems, based on funding, cost, access. But from a science perspective, I think we need to get deeper into precision medicine, where we could maybe, and this is what I'm imagining, one day we'll do blood tests, urine tests, stool samples, and send them to a lab, and they put it through probably an AI type of algorithm, and based on the biomarkers and their metabolomics and their gut microbiome, be able to tell us, oh, this person would benefit the most from an amylin agonist as well as GLP-1, or a GIP GLP-1, or 3 or 4 or 5. So I hope one day we'll get to that, because right now we're using our clinical acumen as best we can, and if this doesn't work, we'll try another one. But I'm hoping, I'm a big fan of Star Trek, so I'm hoping one day we'll just use a tricorder, and I'll just go beep, 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 and then we'll be able to see, which one is best for you, because each person is going to respond differently.
Personalized medicine.
Truly personalized medicine.
Wonderful. Looking forward to have this
I know.
clinical practice.
It'll be fun.
Oh, that's great. Okay, so now usually in the chronic diseases, we used to start with the stepwise approach in treatment. And now we're tackling more than one organ.
Yes.
Probably at the time of diagnosis of diabetes.
Right.
The patient might have already established renal disease or cardiovascular disease. So from your experience, do you think it's the right time to start with a combination therapy, dual protective agents? Is there any scale that this person is at low risk? Let's start with one and build it up. This patient is at high risk. Let's start with dual therapy or triple therapy.
Right.
So please walk us through this.
Yeah, great question. And I think in my own practice, there is a tremendous amount of combination therapy that's being used. Now, I realize that there are access issues in different parts of the world. Fortunately, in the province that I work, it is possible for people to get both an SGLT2 inhibitor and a GLP-1 based medicine and have it be covered. And prevention is better than a cure. No, that's not the word. What is it? An ounce of prevention. Yeah, that's it.
Yeah, that's it.
So it's always better to prevent. And what's beautiful about the therapies we have, so SGLT2 inhibitors is actually the concept of heart failure prevention, which I don't think was something that we had talked about as much in the past, right? We talked about heart failure treatment. But I think now there are enough data to say that it's actually reducing hospitalization for heart failure, and heart failure is a clinical syndrome that manifests with events like hospitalization. So it's actually prevention. I think we can talk about protection of the kidneys and prevention of kidney disease occurring. So the earlier you start, the more likely you can prevent. Now, we do not have specific data on prevention of diabetes, but we kind of do, because we have data with SGLT2 inhibitors in the heart failure studies, in the kidney studies, where they took people with and without diabetes, And in those who did not have diabetes to begin with, some of them had pre-diabetes. And there was less progression to diabetes in those people. So even though we don't have a dedicated diabetes prevention study, it doesn't matter, same thing.
Have the data from the GLP-1 receptor agonist.
Exactly, yeah. So we know that both classes of medications will also prevent diabetes in those who are at risk. So the earlier we start, the better. Like, why would we wait until something happened and then initiate therapy? It just doesn't make sense. And I hope that systems will appreciate that as well. And as time changes and prices change, access will hopefully improve, because globally there's still great discrepancies between countries as to access to these really disease-modifying therapies.
Absolutely, I can't agree more.
Yeah.
Those patients are in the waiting room to have
Yes.
a potential cardiovascular insult.
Yes.
So why wait?
Right.
Absolutely. Can't agree more. Okay, great. That's going very well. Dr. Chang, do you think that the newer cardioprotective medications, they run out of tricks, or we expect more outcomes in near future?
I don't think they've run out of tricks. I think there's always new tricks to be had. One of the lectures that I attended earlier was an update on hypertension. I mean, hypertension, talk about an old disease that we've talked about for a long time, and there's all sorts of tricks up the sleeve in terms of newer treatments that are coming. We haven't solved the issue, right? We have fantastic tools to reduce risk, but it's not zero. By no means is it zero. There are still people having events, developing complications. So there will always be further tools available. Having said that, though, I think if somebody only had this much money, and the question to me is, do we spend this money creating another tool, or do we spend this money to ensure that everybody uses the tools we already have? I would personally spend the money ensuring that people are using the tools we already have. Because I think one of our biggest barriers now is the implementation of all the amazing science that already exists. We already have multiple organ-protecting therapies in the diabetes space and even outside the diabetes space, but the actual percentage of use, when you look at countries, has been improving over time, but it's nowhere near 100%, like not even close. So I think we still need to break that barrier of maybe not inventing new things, but hey, let's use what we have, which is already really, really good. And if we used it in everybody, I think the impact would be tremendous.
Okay, and who are the main players here? Healthcare providers, payers?
Everybody.
Government?
So I would say governments for sure, payers for sure, healthcare professionals to remember, to implement, to advocate, to make that happen. The manufacturers of these therapies from a price point perspective. And then I think the general public, the society also has a big role. So when we talked about the soil, the roots of the tree, society still plays a big role in that piece as well, because the environment we live in many countries is still very conducive to excess adiposity. It's much cheaper to buy fast food than it is to buy fresh vegetables in many parts of the world. The ways our cities are built, it's hard to walk. It's easier to take other transportation. The socioeconomic status and poverty, etc. Like, I mean, there's a million things, I think, from a societal perspective as well. So it's everybody. Everybody needs to play a part in this.
That's brilliant. And you've touched on the general public, that they also play a role. This is a major concern that takes us to a different paradigm. And you've always been ahead of the crowd in so many aspects. And you're very active in the constructive social media side. You have your own channel that I'm sure that have educated millions so far. You agree with me that we are struggling with the the myth that people get from this social media. And they started shying away from continuation of these cardiorenal protective medications. In your understanding, how can we guard against this?
So I think the power of the relationship between the healthcare professional and the individual, we cannot underestimate that. It's actually an incredibly powerful relationship. So when initiating these organ-protecting, disease-modifying therapies, I think we need to frame it properly so that they recognize it's not just to make numbers look pretty on a piece of paper, but that it actually is providing protection. So the analogy I often use is around a car. So when in your car, you've got a seatbelt, you've got airbags, you've got brakes, you've got mirrors, you've got like the lane assist, you've got all these powerful things. Why? Because we want to reduce your risk of getting into an accident or dying from an accident. Now, if you live with diabetes, you're in a speeding car on a highway because we know your risk is high. So we want to give you your seatbelt and your brakes and all of these things. And all of these tools that we use, whether it's a statin, an ACE inhibitor, ARB, SGLT2, GLP-1, et cetera, et cetera, et cetera, they're all seatbelts and airbags. And so I think I find that analogy helpful so that they realize the importance of what it is they're taking. Then I preempt them. I proactively tell them about what they're going to read and what they're going to see. You're going to read about this. You're going to hear about this. This is what I think of these things. Before you make a decision about your medication starting or stopping it, please call. Just call my office, leave a message. We'll have a conversation. I think it's about setting expectations and having that trusting relationship and recognizing what they're reading. And trying to understand why they're choosing to believe what they're reading, right? Because often it's not healthcare professionals providing that noise. It's their neighbor. It's their
unfortunately sometimes
coworker.
The healthcare professionals.
Oh yeah.
Well,
that's a whole other problem.
Instagram and everywhere.
That's a whole other problem. So then, in that situation, we have to drown out those voices by being vocal ourselves and providing information that can counter that information. But it's a challenge. It's a challenge, no question.
It's getting bigger every year.
And it's getting bigger every year. That is true.
Great. So let's shift gears again.
Sure.
To an area that's very close to my heart. Obesity as a cardiovascular risk factor.
Absolutely.
And again, we have a weapon that works on obesity and protects the heart as well.
Yes.
So people still could deal with obesity is just a sort of an outcome of inappropriate lifestyle.
Right.
And it's just numbers.
Right.
So what's your take on that?
Obesity is a chronic disease, right? Obesity is a biologic disorder that is exacerbated by environment, but it is a biologic disorder. It's not a choice that someone has made. And I remember hearing from, I think it was a talk show host in the United States actually, who was making the point that if shaming and blaming would work, there would be no obesity in the world. Because little children who have obesity are constantly made fun of at school and bullied.
Yeah.
And if that was going to fix it, well, they wouldn't have an issue. So clearly, shaming and blaming is completely ineffective for treating a biologic disease. We don't shame and blame someone for hypertension. We don't shame and blame someone. We do, unfortunately, for diabetes, which is also incorrect. But it doesn't work. It's a biologic disease, so we need to address it in those terms as a chronic disease with a biologic basis, and therefore give the tools to address it. But I think healthcare professionals need to check themselves because the bias and the stigma is very real because it's societal. So we grew up as little kids hearing that, watching it on television, seeing it in the movies, and it's still in us. So we need to consciously not perpetuate that stigma, and that requires effort for us to do that.
And we have to be role models as much as we can.
Yes.
Yeah.
That's right.
That's brilliant. And now there is sort of big advocacy to consider obesity as a chronic, relapsing, debilitating neurobehavioral condition.
Yes.
And with the an outcome that might be associated with more than 200 diseases so far.
Correct.
So, what's your advice to our colleagues in healthcare providers, professional societies, payers, governments? And we need to move towards. There are few countries that have already recognized obesity as a chronic disease. So, what's your loud voice advice to everyone?
One of the best sayings I've ever heard from anyone is from Professor Carl LaRue, who you probably know well, and he says it's not about weight loss, it's about health gain.
Oh.
And I love that statement. I just absolutely love that statement, because what it does is it takes the focus away from the number on the scale, because the number on the scale is a surrogate marker. And sometimes when payers and the lay public hear about weight loss, they're just imagining, oh, someone wants to fit into a dress, someone wants to look a certain way. But no, we're talking about health gain. We're not talking about just losing weight. And I think if we reframe it as it's about gaining health, then that will impact budgets from a healthcare perspective, right? And will also improve productivity of your entire population. Because it's not just about saving money because of less heart attacks and less heart failure, it's about greater working capacity of the individual who can then contribute to the GDP of the country and actually contribute to the economy. So it's actually about health gain, which then will translate into country gain. Right? The country will benefit from a healthier population. So maybe it's shifting from the concept of weight loss and the concept of health gain and prevention of complications. I just love what Carl said, though. To me, that really resonated. And I've said that directly to patients, and they've loved it too. Because they also realize, oh yeah, it's maybe not so much about the number on my scale, but hey, I'm on less blood pressure medicine, or oh yeah, I think I feel better. And I think we need to refocus that.
Wow, brilliant. So it's not about weight loss, it's about weight gain.
About health gain, correct, sorry. Yes.
Perfect, brilliant. Okay, well, we tend to get this question on daily basis. How long should we go on medical intervention in treating obesity?
It's meant to be lifelong, because it's a chronic disease. It's a chronic relapsing disease, and it's neurobehavioral. It's a biologic condition. We haven't changed your genetics. We haven't changed your biology. What we're doing is we're helping the process. We are making it easier, is the right word, to make different choices, because we're changing that noise that's in your head. So the intention is to continue lifelong. Now, what we can do is play with the dosage, because you may not need the highest dose all the time. We may be able to lower the dose a little bit, see how you feel. And I always tell the patients, you're driving the bus. So if you feel like, you know what, I think I've plateaued, I think I like where I am, I'm going to try a lower dose, I say, sure, try a lower dose. And if you start to notice, oh, you know what, that noise is coming back, and I'm now back to eating more and I can't control it quite as well, okay, well then maybe we go back up. So we sort of can fluctuate based on what they need. But I always set that up from the beginning. This is not a 3 months and you're done. This is not how this is going to work. Especially if I'm protecting your organs, then as long as you have a heart, as long as you got a brain, as long as you got kidneys, we should continue to protect.
Absolutely. And now we have the evidence that when we discontinue the medication, not only the weight comes back, it's even the cardiovascular risk factors, they all come back.
Yeah.
Just like the baseline.
Yeah, because the underlying hasn't changed. We've not given them new genes or a new brain or a new biology, right? It's still the same person. We've just taken away the tools to help them, which is, I think, worse.
Excellent. And one final advice, that we all go for the quick fix.
Yes.
We like the quick fixes.
Yes.
So is it a replacement of an optimum lifestyle?
No. It absolutely not a replacement. It is, though, a tool to allow people to do the things that they know have been advised but have been difficult to do. And they've probably blamed themselves their whole life thinking, I'm a bad person, I don't have the willpower, I don't know what's wrong with me. But that, it wasn't their fault, right? I mean, the biology, the genetics, the signals in their head were countering all those efforts. We're now giving a tool to help that. So if anything, it's actually helpful for people to do the lifestyle that we know is helpful. So this does not replace lifestyle in any way, shape, or form. This is not an easy way out. This is not cheating. Those are all the terms that I've heard, which they really bother me because it's a lack of understanding of the real issue.
Absolutely. And maintaining the lifestyle will even prevent the consequences of having these medications from happening.
Correct.
Like sarcopenia.
Correct. Absolutely. Completely agree.
Excellent. And definitely lifestyle will make them fitter.
Yes.
Longer period.
And happier.
Yeah, absolutely.
Right? Just from a mental health perspective, huge benefits.
Yesterday you were talking also about longevity.
Yeah.
Yeah, this might add a lot.
Yeah. Agreed.
Great. Professor Chang, it has been brilliant and wonderful
pleasure.
chat. Thank you very much for coming all the way to Dubai, and
Thank you.
looking forward to see you again and again in EDIC, the next version and the version afterwards. And if you have any statement that to conclude our conversation.
Well, first, thank you to the organizing committee. I mean, this has been a wonderful experience, and I would be more than happy to come back anytime you guys call.
Our pleasure.
And I think for the audience, it's use the tools that we have, and we have incredible tools, and protect your patients with all the tools that we have at our disposal, because we know that will ultimately lead to hopefully longer life, but if not longer, at least better in terms of less complications.
Brilliant. Thank you very much, Professor Alice Chang, and thank you everyone for being around, and see you in the next wave of EDIC Studio.